From 1988, right after attaining her AB Political Science degree, until 1991, she also worked as a Foreign Affairs Research Analyst for the Research Development Center of the Foreign Service Institute, the research and training arm of the Department of Foreign Affairs. She has recently joined the Philippine Foundation for Vaccination as legal consultant. She is likewise a founding member of the Immunization Partners in Asia Pacific, an organization focused on immunization advocacy. Friends and colleagues, let's all welcome our first speaker, Attorney Maria Divina Andaya Carandang.
I know it's very cold and it's too nice to stay in bed. So thank you very much. I just hope that I don't put you back to sleep. Well, anyway, I also would like to say that I'm very honored to be in front of people who are actually in the field of health. You know, I may speak about the right to health, but I know that you are actually living it on a daily basis. So you're doing it not as part of your obligation, but it is actually a vocation on your part. But while they're still doing the slides, taking care of it, I just hope that before you leave this room or after this lecture, I'll be able to impart some of whatever little knowledge I may have, and from the legal standpoint. And also, I hope that when you leave here today, you'll leave armed with the knowledge that whatever you're doing on a daily basis, you will know that you are actually backed by international and local laws. So are we ready? Okay. So today I was tasked to deliver a speech, to speak on the right to health and vaccination. Okay. According to the WHO, or the World Health Organization, 6.9 million children died in 2011, and these are children under 5 years old. 6.9 million a year. That is nearly 19,000 a day, or 800 per hour. Of these figures, 70% died within the first year of life, and 58% are caused by infectious diseases. The WHO also identified the leading causes of death under 5 as pneumonia at 18%, number 2, preterm birth complications at 14%, diarrhea at 11%, birth asphyxia at 9%, and malaria at 7%. Also, the WHO noted that more than half of these early child deaths are due to conditions that could be prevented or treated with access to simple, affordable interventions. They also noted that about 1/3 of all child deaths are linked to malnutrition. Okay, it is worthy to note that the special circumstances of children can best illustrate the importance of the promotion and protection of the human right to health. Again, let me quote a WHO report that identified some of the contributing factors in cases of pneumonia and diarrhea. And the report says that pneumonia and diarrheal diseases are the leading cases of child death globally and can be a particular problem, most especially in urban areas, due to crowding, indoor air pollution, poor access to health care, contamination of water, inadequate sanitation, and lack of solid waste disposal. It also said that the gastrointestinal illness can lead to malnutrition and death, especially among younger and undernourished children who still have poorly developed immune defenses. For similar reasons, children in urban areas are susceptible to death from malaria and vaccine-preventable diseases. However, I'd like to add to that it is not only in urban areas. I believe it is also a big factor in rural areas. But in urban areas, they also identified that road traffic injuries among children are also of significant concern, and the lack of consideration to children in urban and transport planning contributes to this problem. Allow me to say, however, that this should not, must not, could not, and would not have been the situation if and only if each and every one of us should guarantee, promote, and protect the human right to health. But what is the human right to health? Although the right to health, like taxes, exists from womb to tomb. I'd like to emphasize that. Like taxes, it exists from womb to tomb. It is closely intertwined with the inalienable rights to life, liberty, and pursuit of happiness. Health is indispensable to the full enjoyment of other rights, such as the right to education, the right to travel, the right to work, freedom from poverty, freedom of expression, and even the right to vote. But the right to health is likewise highly dependent on the protection and fulfillment, promotion of other human rights and freedoms. I would like to illustrate this by using this flower diagram. See, I compared it to a flower plant. The rights that you see at the bottom, which is the right to food and water, the right to proper sanitation, the right to environmental protection, the right to shelter, right to information, and freedom from discrimination, these are not exclusive, by the way. These are just some of the rights. These are what we call the underlying determinants of health. In a plant, this serves as like the roots. Without these rights, the flower plant cannot survive, and that is the right to health. That flower will die without protecting the rights at the bottom, which serves as the root that feed the plant. And if the flower dies, also your different rights are affected. A child who is sick or dies before the age of 5 can never go to school. So the right to education, it will not happen. An adult who is sick cannot go to work. If you cannot go to work, you cannot be assured of your freedom from poverty. You cannot exercise your right to associate. You cannot exercise even your right to vote. Malapit na po ang eleksyon. So if you cannot get out of bed and you're sick, you cannot go to the precinct, you cannot vote. So I think the politicians should take notice of this. You have to ensure the health of your people, of your constituents, and your voters. So you see, the right to health is very much there is an interdependence among other human rights. So if you protect the right to health, you are in turn protecting also those rights that are interdependent and linked to the right to health. Although the right to health is not as loudly and boldly advocated for as other human rights, rest assured that it is embodied in both international and local enactments. The Universal Declaration of Human Rights states everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing, and medical care and necessary social services. But what is the right to health? The right to health, as emphasized in Article 12 of the International Covenant on Economic, Social, and Cultural Rights, referred to the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. It embraces a wide range of socio-economic factors that promote conditions in which people can lead a healthy life, and extends to the underlying determinants of health such as food and nutrition, housing, access to safe and potable water and adequate sanitation, safe and healthy working conditions, and a healthy environment. Article 24 of the United Nations Convention on the Rights of a Child provides that the states parties recognize the right of the child to the enjoyment of the highest attainable standard of health. Again, what do we mean when we say the highest attainable standard of health? The notion of the highest attainable standard of health, which was elucidated in Article 12.1 of the International Covenant on Economic, Social, and Cultural Rights, takes into consideration the individual preconditions and the state's available resources. The individual preconditions compose of the biological, the social, the cultural, and the economic preconditions. And of course, the state's available resources refers to the ability and the capacity of the state to provide all the facilities, the goods, and all the underlying determinants of health. There are a number of aspects which cannot be addressed solely within the relationship between states and individuals. In particular, good health cannot be ensured by a state, nor can states provide protection against every possible cause of human ill health. Thus, genetic factors, individual susceptibility to ill health, and the adoption of unhealthy or risky lifestyles may play an important role with respect to the individual's health. Consequently, the right to health must be understood as a right to the enjoyment of a variety of facilities, goods, services, and conditions necessary for the realization of the highest attainable standard of health. The Committee on Economic, Social, and Cultural Rights, on its comment number 14, identified two components of the right of health. It says that it consists of both freedoms and entitlements. The freedoms are the right to control one's health and body, including sexual and reproductive freedom, and then the right to be free from interference, which includes the freedom from torture, cruel, or degrading treatment, and the freedom from consensual medical treatment and experimentation. By contrast, the entitlements include the right to a system of health protection providing equality of opportunity for everyone, prevention, treatment, and control of diseases, access to essential medicines, maternal, child, and reproductive health, equal and timely access to basic health services, health-related education and information, and participation in health-related decision-making. To guarantee these freedoms and entitlements, the obligation to respect, protect, and fulfill are imposed on states by the ICESR. However, it is worthy to note that these obligations apply also to everyone at varying levels. Again, if you would look at the diagram, the biggest circle refers to the obligation of the international community, which include the state, the community, the family, and the individual. The states, on the other hand, covers the communities, the families, and the individual, and then the community to the family to the individual. Okay, as to the obligation of the international community, it is usually fulfilled by adopting covenants in international and regional levels, guaranteeing and observing the right to health of individuals by imposing upon member states certain obligations. Needless to say, the states have the primary responsibility to respect, protect, and fulfill. In fact, the ICESR has identified core minimum obligations of states, which include the provision for the reduction of the stillbirth rate and infant mortality and to the healthy development of the child, the improvement of all aspects of environmental and industrial hygiene, the prevention, treatment, and control of epidemic, endemic, occupational, and other diseases, and the creation of conditions which would assure to all medical service and medical attention in the event of sickness. Likewise, all entitlements, as discussed before, entitlements components of the right to health are essentially the responsibility of the state to provide. The communities, however, and the private sectors are equally obliged to observe, promote and respect this right not only by not violating the freedoms components, but by ensuring that the underlying determinants of the right of health, such as the environmental protection, clean water, proper sanitation, are guaranteed. Families and individuals, in addition, should not only avail of such entitlements, but fulfill individual rights by providing for their own families, most especially the children, the highest attainable standard of health, as proactively by guaranteeing the socioeconomic factors, freedoms, and entitlements which are within their control. What do I mean by this? I mean that if a child within a family, the highest attainable standard of health should also apply. So if you are in a family, a very rich family, and you forgot to take your children to the doctor, that may be a consideration. That may be considered as a violation of this right. Because as a family, or as members of that family, you also have the obligation to protect, fulfill, and respect the right of the child. Various challenges, however, ranging from lack of political will, to lack of resources, to lack of awareness, hinder the full enjoyment of the right to health. Although health protection in the health system can never be simplified, we can, however, try to identify and prioritize the strategies on how to best approach such challenges. And this is where vaccination play a role. One of the core minimum obligations of the state in view of the right to health is the prevention, treatment, and control of diseases. As previously presented in the beginning, more than half of under 5 deaths could have been prevented by simple interventions such as proper nutrition, exclusive breastfeeding, clean water, adequate sanitation, and vaccination. In fact, the WHO also said that for some of the most deadly childhood diseases such as measles, polio, diphtheria, tetanus, pertussis, pneumonia, and streptococcus pneumonia and diarrhea due to rotavirus, vaccines are available and can protect children from illness and death. Vaccines have been identified as one of the most cost-effective means to prevent diseases. However, as experts like say, vaccines don't save lives. Vaccination does. And even the World Health Organization has reiterated this, and it said, immunization is a proven tool for controlling and eliminating life-threatening infectious diseases and is estimated to avert between 2 and 3 million deaths each year. It is one of the most cost-effective health investments with proven strategies that make it accessible to even the most hard-to-reach and vulnerable populations. It has clearly defined target groups. It can be delivered effectively through outreach activities, and vaccination does not require any major lifestyle change. This was further reiterated during the 65th World Health Assembly, attended by 194 ministers of health from different countries. And this was in May 2012, where it declared that immunization is and should be recognized as a core component of the human right to health and an individual, community, and governmental responsibility. I was told to wrap up. Okay. Okay, and during this 65th World Health Assembly, the Global Vaccine Action Plan was also endorsed. What is the GVAP? The GVAP is a roadmap to prevent millions of deaths by 2020, which was identified as part of the decade of vaccines. 2011 and to 2020 was identified as the decade of vaccines, and the GVAP is supposed to be the roadmap to prevent millions of deaths by that time through more equitable access to vaccines for people in all communities. And the GVAP identified 6 strategic objectives and 6 underlying principles. And what are these? Country ownership, that it means that the countries should prioritize vaccination. Number 2, communities and individuals demand, which means communities and individuals should be informed and should have the shared responsibility to demand vaccination as a right, as part of their right to health. Equity, meaning equitable access to immunization as a core component of the right to health. Integration, which means immunization system should be integrated and closely coordinated with other primary healthcare delivery programs. Sustainability and innovation, which refers to research and development. Okay. Now, as I've said, it is the state who has the primary responsibility to respect, protect, and fulfill the right to health. And in the Philippines, the 1987 Constitution provides that the state shall protect and promote the right to health of the people and instill health consciousness among them. Again, it was further reiterated in Article 18, Section 11, when it says that the state shall adopt an integrated and comprehensive approach to health development, which shall endeavor to make essential goods, health, and other social services available to all the people at affordable cost. And in response, the DOH, or the Philippine government, adopted the universal health care, which aims to provide every Filipino with the highest possible quality of health care that is accessible, efficient, equitably distributed, adequately funded, fairly financed, and appropriately used by an informed and empowered public. It identified 3 strategic thrusts, which is financial risk protection, and this is in partnership with the National Health Insurance Program of the Philippines, improved access to quality hospitals and healthcare facilities, and the attainment of health-related MDGs. The Philippines has likewise been very aggressive in the field of vaccination. It has adopted several laws relevant to the immunization, most notable of which is RA 10152, also known as the Mandatory Infants and Children Health Immunization Act of 2011, which you are very much aware of. And RA 10152 provides mandatory immunization for tuberculosis, diphtheria, tetanus and pertussis, poliomyelitis, measles, mumps, rubella or German measles, hepatitis B, HIV, and such other types as may be determined by the Secretary of Health in a department circular. And last year, the DOH introduced rotavirus in the NIP, and I think this year they will also launch, or maybe early next year, the PCV. But the Philippines does not focus only on children. It also adopted the Expanded Senior Citizens Act of 2010, which addresses the needs of the elderly. And it provided free vaccination against the influenza virus and pneumococcal disease for indigent senior citizen patients. If the senior citizens are not indigent, this law also provides for discounted vaccine costs, pneumococcal vaccine costs for senior citizens. And recently, I've just read that the PhilHealth partnered with MSD to provide discounted vaccines to elderly I think at 60% discount. But again, I would like to reiterate that this is just the obligation of the state. It is everyone has the obligation to respect, protect, and fulfill the right to health. Not just the government or the public health workers. We have to do our part to achieve this. And we could use the GPAP and its guiding principles as a roadmap that we can use. The MDGs are midterm goals that we can aspire for. Let us work together to ensure that the right to health is respected, protected, and fulfilled. We at the IPAP, we see a world where no person shall suffer from vaccine-preventable diseases, and a society where public health is at the forefront of every governmental program and policy. And how do we intend to do this? Through a real and genuine partnership with different stakeholders, by employing collaboration, cooperation, coordination, communication, and more importantly, consultation. The bottom line is, we have to work together, not just for ourselves, but most importantly, for the children who not only cannot fight for their right to health, but also are helpless and defenseless. As Dr. Lulu always says, children cannot speak for themselves. Yes, they cannot speak for themselves, they cannot fight for their rights, but we can, so let us. Thank you.
Maybe call on stage. Had her BS Pre-Medicine at the University of the Philippines, Diliman, Doctor of Medicine at the UP College of Medicine, Residency in Pediatrics at the Medical City, Fellowship in Infectious Diseases at the UPPGH and at the Research Institute of Tropical Medicine, and completed a basic course in vaccinology in Bethesda, Maryland, USA. She is presently a consultant director at the NICU, the Medical City. She heads the Division in Patient Care at the Department of Pediatrics, the Medical City. She is also the head of the Hospital Infection Control Committee, EXICOM. She's a member of this at the Medical City. She is the chair of the Committee on Immunization of the PIDSP. She co-chairs the Committee on Immunization of the Philippine Pediatric Society, and she co-chairs the Committee on the Handbook of Pediatric Infectious Diseases of the PPS. To talk on the topic of immunization recommendations for children and adolescents, let us all welcome Dr. Cynthia Alcantara Aguirre.
Good morning to all. It's good that a lot of you came back for the second day. We started early. I know it's hard to come very early after the fellowship night. I think a lot of people had a good night after that. So I think a lot of you awaits this session because Dr. Tabora had already given an introduction yesterday about this childhood immunization schedule. But before I begin, let me tell you that the society as a whole does not bring out the recommendation by itself. PIDSP is just one society who works in the recommendation. The process starts with the Committee on Immunization, composed of members of the society who reviews the various vaccines and evidences and comes up with a recommendation per year. Once this is approved, it is brought to the PIDSP board for approval. And once the approval is given, we bring it and present the recommendations to PPS, who gives the approval. And for this year, PPS will present it to the various stakeholders before it can finally be brought out by the Philippine Foundation for Vaccination for printing and dissemination. So what I'm going to present to you will just be the output of the Committee on Immunization of PIDSP because it will still have to be presented to PPS for approval and this has to be presented to the stakeholders before we really can come up with the 2013 recommendation for children. So these are all preliminary. But what I'm going to present to you are the suggested changes by the committee, and it may still not be final. Okay. So this is one of the proposed changes in the 2013 immunization schedule. Whereas before, we only had one calendar, and this comprises children from age 0 to 12 years old, and you have the following vaccines in the annotation. So it's a lot. We did not separate it based on age group. For the 2013 calendar and recommendation, we decided to separate the calendar into two age groups. The 0 to 6 years old, wherein you have the following vaccines, and the 7 to 18 years old, where you have the following vaccines. You will see that Tdap, HPV is no longer in the 0 to 6 because based on the recommendation, they are for older children, so they will be brought to the 7 to 18 calendar. So basically, if PPS approve this, we will have two calendars and two annotations. The other changes will include vaccines for special groups. In the 2012 calendar, we had 3 vaccines for special age groups: typhoid, rabies, and meningococcal vaccine. For 2013, we again divided it into 2 age groups. It will be the same for the 0 to 6, and for the 7 to 18, we have included the pneumococcal vaccine. So we will review the various annotations. We have not gone through the calendar. These are just the annotations which Dr. Tabora yesterday stated that you really have to read, so yet you can really understand how the calendar works. For the BCG recommendation, the 2013 recommendations has not changed from the 2012. It still remains the same. It's given at the earliest possible age after birth, preferably within the first 2 months of life. And you don't need to give PPD for healthy children prior to BCG if they're more than 2, unless you have any of the following symptoms, like suspected congenital TB, history of close contact with infectious case, clinical findings suggestive, or X-ray findings suggestive of TB. So if you have these conditions, then you have to do a PPD. And if your PPD is 5 or more, then that's considered positive. And we gave the various doses of how to give BCG. For less than 12 months, it's 0.5, and for more than 12 months, it's 1 ml. So 2013, it's the same. For measles, there has no changes in the recommendations. But then this will only be put in the 0 to 6 years age group. The 7 to 18 age will have no measles recommendation because we give measles only in children below 1 year of age. So there is no change, no? It's given at 9 months and can be given as early as 6 months in outbreak situations as declared by public health officials. No? So you really have to work with the government for these bulletins. Now, if you gave measles at less than 12 months of age, you still need to give 2 doses afterwards. And this will be addressed by MMR. Now, for the rotavirus vaccine, this is already included in the EPI program. No? It's given per ORM, and you have 2 vaccines available. The human rotavirus vaccine, which is monovalent, and which is given as a 2-dose series at age 6 weeks, and the second dose should not be given later than 24 weeks. And the pentavalent human bovine rotavirus vaccine, again, which is given as a 3-dose series as compared to the first, with the first dose given between 6 weeks and 14 and 6 days of age, and the last dose at 32 weeks of age. The minimum interval between doses is 4 weeks. Now, DOH has come up with its own recommendation, and we're trying to harmonize DOH with our recommendation. But the problem is, the vaccine that DOH gives may change every year because they go into bidding. So we do not know which vaccine will be available next year. It will depend on the bidding, which may be local, if they have suppliers, or international if they come from UNICEF. So until we can get a clear-cut recommendation from DOH, we're going to stick with this recommendation. So for this year, DOH was giving the 2-dose series. We don't know what they're going to give next year based on the bidding, so their recommendation may change again next year. So we're going to stick with our 2012. The same for hepatitis B vaccine. In 2012, this is our recommendation. We give the first dose within first 12 hours of life, and this may be counted as part of your 3-dose primary series. Then the subsequent doses are given 4 weeks apart, but the third dose should preferably be given not earlier than 24 weeks of age. Now, a 4th dose is given in the following situations. The 4th dose is not a booster dose. It will become part of your series if the 3rd dose is given at less than 6 months of age, if you follow the EPI program of birth, 6 and 14 weeks, and if you give it to prematures. Now, we also gave recommendations for immunization for preterms in mothers who are HBs negative. And here, if you have a premature infant born to an HBs negative mother, you can wait 30 days before giving the first dose, and this is counted as part of your primary series. If the mother is HBs positive, you have to give hepatitis B at birth and HPIG, and of course, give 3. This is not counted as part of your primary series, so you still have to give 3 doses. And if it's unknown, you have to give hepatitis B at birth, and it is suggested that you do screening of the mother, and if the mother turns out to be positive, to give the HPIG within 7 days of life. Now, for the 2013 recommendation, the committee recommended that we have the same recommendation for the 0 to 6, but we have written a recommendation for the 7 to 18 years of age. Again, the recommendation, which is not final, is that you administer 3 doses following a 016 schedule to all previously unvaccinated children. For hepatitis A, it's the same. The 2012 encompasses the 0 to 18 age group. Now we have divided it into 0 to 6 and 7 to 18. Basically, you give 2 doses with at least 6 months interval between doses for both groups. For the HPV vaccine, again, it's quite tricky. You have 2 vaccines available. Both are given intramuscularly. Both vaccines consist of a 3-dose series administered to ages 10 to 18 years of age. You might wonder why 10 when the vaccine company recommends at 9. This is based on the committee agreement that most kids follow at age 10 because they follow the 10-20 schedule where you give the boosters. The recommended schedule is shown in the following. For bivalent vaccine 016, quadrivalent HPV 026, the minimum interval between the first and second dose is 4 weeks, and the minimum interval between the second and third dose is at least 3 months. For the 2013, the HPV will be part of the 7 to 18 calendar. And the change that we recommend is that the third dose should be given at least 6 months after the first dose. Now, use of quadrivalent HPV in males 10 to 18 years of age for the prevention of anogenital warts is still optional, although the states is already part of their routine recommendation. Here we feel that because we have not increased the percentage of females, young adolescents, immunized against HPV, we still need to push for broader coverage, at least more than 70%, for the vaccine to be cost-effective and to be given to males. You really have to start with females first, because only by vaccinating females can we really get good coverage and later on go to the male adolescents. Haemophilus influenza is basically the same. This is only recommended for children 0 to 6. I'd like to point out at the bottom paragraph, 1 dose of Hib vaccine should be considered for unimmunized children 5 years or older who have sickle cell disease, leukemia, HIV infection, and those who have had splenectomy. It has not changed. The recommendation is basically the same. The same with OPB. It's given, we have 2 preparations, the IM preparation, which used to be part of a combination vaccine, but now a company has come up with standalone or monovalent IPB, and the OPB, which is given per RM. The minimum age is 6 weeks of age. You have a 4-week interval. The final dose of the series should be given on or after the 4th birthday, and it should be at least 6 months from the previous dose, which is the 3rd dose. Okay. If 4 more doses have been given prior to age 4, additional doses should be administered at age 4 to 6. Okay. If a combination of OPB, IPB are given as part of a series, a total of 4 doses should be administered regardless of the child's current age, and it is preferred that IPB be given. For DPT, we have 2 preparations. Our local government gives the whole cell pertussis, the DPT with the whole cell pertussis component, and the combination vaccine contains a cellular pertussis in their combination vaccine. This vaccine is given intramuscularly, minimum age of 6 weeks with a minimum interval of 4 weeks between doses. The 4th dose may be given as early as 12 months, provided there is an interval of 6 months from the 3rd dose. The 5th dose may not be given if the 4th dose is administered at age 4 years or older. For the 2013, the recommendation will remain the same, but this will be part of the 0 to 6 calendar. Now for Tdap, the 2012 recommendation covers 0 to 18. You just have to read through it. Now, we have decided to put this in the 7 to 18 age group. No? And this is the recommendation. We broke it up into children who are fully immunized. If your child is fully immunized, meaning they've had the primary series, including the booster, TD booster should be given every 10 years. And in this recommendation, a single dose of Tdap can be given in place of the due TD dose and can be administered regardless of the interval since the last tetanus diphtheria-containing vaccine. Remember, for the 2011, they gave an interval of at least 3 to 5 years from the last TD-containing dose. Now you can give it regardless of the interval. Now, if your child is 7 to 18 and is not fully immunized with DPT vaccine, they should be given a single Tdap, and the remaining doses should be given as TD. And for children 7 to 18 who have never been immunized with DPT, they should receive a 3-dose series of tetanus-containing vaccine using the 016 schedule, and a single Tdap dose is used as the first dose, preferably as the first dose, with the succeeding doses as TD. And this will be the same for the 2013 recommendation. PCV is the same, there is no change. It is recommended that you use the conjugate vaccine starting at 6 weeks of age. And if you're going to use pneumococcal vaccine, you give it at 2 years of age. If the child is healthy and you've completed the PCV series, you don't need to give the polysaccharide vaccine. However, the polysaccharide vaccine is recommended for children who are high risk and more than 2 years of age, in addition to your conjugate vaccine. For MMR, the 2012 and the 2013, 0 to 6 years old is the same. The minimum age is 12 months. The second dose is administered at 4 to 6 years, but may be administered at an earlier age, provided the interval between the first and the second dose is at least 4 weeks. For example, during the last outbreak of measles 2010 or 11, there was an outbreak of measles and DOH were giving measles and MR vaccine. We had to address that. If the child below 12 years of age was given any measles-containing vaccine, meaning measles, rubella, or MMR, they should be given 2 additional doses of MMR. The first dose given at 12 months, 12 to 15, separated by at least 4 weeks from the measles-containing vaccine. The second dose is administered at age 4 to 6 years, but may be given at an earlier age, provided you have a 4-week interval. Now, children aged more than 12 months, given 1 dose of any measles-containing vaccine, again, measles, MR, MMR, should be given a second dose of MMR, separated by at least 4 weeks from the first measles-containing vaccine. This will be the same for the 0 to 6, 2013. And for the 7 to 18 years old, the recommendation is to give 2 doses of MMR with a minimum interval of 4 weeks between doses. Now, in children 7 years or older who have received 1 dose of any measles-containing vaccine, you only need to give 1 dose of MMR. Now, for varicella, it's basically the same like MMR. You start the first dose at 12 to 15 months. The second dose is given at 4 to 6 years of age, but may be given earlier, provided there is an interval of at least 3 months between the first and the second dose. Now, a second dose of the vaccine is recommended for children, adolescents, and adults who previously received only 1 dose. And if you're more than 13 years of age, you need 2 doses with a minimum interval of at least 4 weeks. Now, for the 2013 0 to 6 age group, it's basically the same as 2012, except that we added the letters in red that if you administer the second dose at least 4 weeks after the first dose, it can be considered as valid. No, so this will be the only addition. And this will be the same for the 7 to 18. For children below 13 years of age, the recommended minimum interval between doses is 3 months. However, if the second dose is administered at least 4 weeks from the first, it can be considered valid. So those will be the changes that we recommended. MMRB has no change. It's given as an alternative to separately administered MMR and varicella vaccine for children 12 months to 12 years. The minimum interval between doses, you need 2 doses. The second dose may be given at 4 to 6 years of age, but can be given earlier provided you have an interval of 3 months between doses. And basically, it's given, there is no change in the recommendation for both the 2013 calendar. Now, for influenza vaccine, this was the recommendation last year. You know, influenza is given either IM or sub-Q for all children 6 months to 18 years of age. They should receive influenza vaccine. For children 6 months to 8 years who are receiving influenza for the first time, you need 2 doses separated by a 4-week interval. Now, if only 1 dose is given during the previous influenza season, you administer 2 doses the following year, and then 1 dose yearly thereafter. However, this year, because the current strains in the 2012 vaccine has remained the same from the previous season, it is recommended that children aged 6 months to 8 years who receive at least 1 dose of the 2011 vaccine will require only 1 dose of 2012. This was the recommendation for this year. For the following year, 0 to 6, it's basically the same. If it's the first time, 6 months to 8 years, child with no influenza vaccine, they're supposed to be given 2 doses, no? Separated by 4 weeks. Now, for children 6 months to 8 years who have received a total of 2 or more doses of seasonal influenza since 2010, they should receive single annual doses. If only 1 dose was administered since 2010, and you're 0 to 8 years of age, 6 months to 8 years of age, you should administer 2 doses of the vaccine for the current year, then 1 dose thereafter. This is to make sure that this child receives at least 2 doses of pandemic influenza vaccine. The same is true for the 7 to 18, because this still comprises the 6 months to 8 years of age. If you have received a total of 2 doses since 2010, you should receive only 6 single annual doses. But if you only receive 1 dose since 2010, you should administer 2 doses of vaccine, then 1 dose yearly thereafter. This is only for children. This is for the 6 months to 8 years of age. Children 9 to 18 years of age should receive 1 dose of the vaccine annually. Now let's go to vaccines for special groups. Now, vaccines for special groups these are vaccines that are not part of your EPI program or recommended vaccines, but data supports its use in certain conditions or populations. For 2012, the 0 to 18 years of age, there were 3 vaccines that were part of your vaccines for special groups in children: your typhoid, meningococcal vaccine, and the rabies vaccine. For the 2013, the 0 to 6 vaccines included are the same, but for the 7 to 18 years of age, we decided to include a pneumococcal vaccine. There are no changes in the recommendation for typhoid and rabies vaccine. They remain basically the same for 2013. No. Remember, these are vaccines for special groups. So these are recommended for travelers to areas where there is risk for exposure for Salmonella typhi or for outbreak situations as declared by public health. A single dose may be given as early as 2 years of age, with revaccination every 2 to 3 years if there is continued exposure to Salmonella typhi. And for the rabies vaccine, the recommendation has not changed. This is basically a pre-exposure recommendation, and this is recommended for children ages 5 to 14 years of age based on the Anti-Rabies Vaccine Act of 27. There are 2 doses that are recommended: the intramuscular dose given on days 0, 7, 21, or 28 days, and the intradermal dose, which can be given on days 0, 7, 21, or 28 days. Now, you have to repeat the dose if the vaccine is given subcutaneously. And it should never be given in the gluteal area because absorption is very unpredictable. Once you've received the pre-exposure prophylaxis, periodic booster doses in the absence of exposure is not recommended for the general population. However, if there is exposure for those who have completed the 3-dose series, if you are exposed or beaten again, regardless of the interval between re-exposure and the last dose of the vaccine, you only need 2 booster doses at age 0 and 3 days. And this can be given either as IM or as an intradermal dose. You don't need to give rabies immune globulin if you've been given pre-exposure prophylaxis. Now, the meningococcal vaccine is also for special groups. There are a lot of vaccines available. We have the tetravalent meningococcal conjugate vaccine. We have the tetravalent meningococcal polysaccharide vaccine and the bivalent meningococcal polysaccharide vaccine in the market. So we have a lot of meningococcal vaccines available. but the conjugate vaccine has already come out. This is recommended for children 2 to 18 years of age at high risk for invasive meningococcal disease, meaning you have either anatomic or functional asthenia, complement or factor deficiencies, HIV. These children who are at high risk should receive 2 doses of the vaccine given 2 months apart. The vaccine recommended preferably is the conjugate vaccine. For example, you gave a polysaccharide vaccine for high-risk individuals as the first dose. The second dose recommended is a conjugate vaccine. It's recommended that you give the second dose, and this be a conjugate vaccine. Now, revaccination for the conjugate vaccine in persons who are high risk is recommended every 3 to 5 years. So if you're going to revaccinate, it's preferred that you give the conjugate. In outbreak situations like what happened here in Baguio in 2005, meningococcal vaccines, regardless of type, may be given using this can be given as early as less than 2 years of age, with a minimum age of 3 months, using 2 doses 3 months apart. I think this was given here in Baguio when the outbreak occurred in 2005. Now, the 2012 recommendations for meningococcal vaccine refer to children who are high risk starting at age 2. I'm sorry. Yeah. Sorry. Can you hear? Okay, I'm sorry. Okay, for the 2013, remember we divided the vaccines for special groups into 2, the 0 to 6 and 7 to 18. So you're going to have 2 calendars. For the 0 to 6, in this year's recommendation, the earliest age you can give meningococcal vaccine is 2 years. Now we have brought it down to 9 months. No. And this is for children at high risk for invasive disease, and the high risk category has expanded to include persistent complement component deficiencies, travelers to or residents to areas where meningococcal disease is hyperendemic or epidemic, or belonging to a defined risk groups during a community or institutional meningococcal outbreak. And these high risk individuals should receive 2 doses of the vaccine given 2 months apart. If the person remains at high risk, an initial booster dose of the conjugate vaccine should be given 3 years. In the previous recommendation, it was 3 to 5 years. Now, it should be given 3 years after completing the primary series of 2, with continued booster doses at 5-year intervals after initial booster doses. Again, if you gave the polysaccharide vaccine in the high-risk individuals as a first dose, a second dose should be given using the conjugate vaccine. Now, we mentioned here, and we like to emphasize that additional booster doses of the polysaccharide vaccine, whether tetravalent or bivalent, are not recommended. And for the 7 to 18, we just brought up the age to 18 years of age with risk for meningococcal disease. But basically, the annotation is the same. Now, the last part is pneumococcal vaccine. This will be part of the high-risk groups age 7 to 18. And this is given intramuscularly. We stated that only children with the following underlying medical conditions should be given pneumococcal vaccines, like those with anatomic or functional asthenia, HIV infection or other immunocompromising condition, cochlear implant, or cerebral spinal fluid leak. A single dose of PCV13 may be administered to children aged 6 to 18 years with this underlying medical condition. You administer the polysaccharide at least 8 weeks after the last dose of your PCV13 to children aged 2 to 18 years with this underlying medical condition. And a second dose of PPB is recommended 5 years after the first dose of your polysaccharide pneumococcal vaccine. No more than 2 polysaccharide vaccine doses are recommended. And this is the recommendation. And these are the members of the Committee on Immunization. We'd like to inform you that this has been approved by the PhD board. Now, the process is that it will have to be presented to PPF for approval. And once this is approved, it will go to PFB for printing and dissemination. Thank you.
For our next speaker, she is a full professor of the Faculty of Medicine and Surgery, University of Santo Tomas, the Chief Section of Infectious Diseases, Department of Medicine, UST Faculty of Medicine and Surgery, and Santo Tomas University Hospital, the Chair of the Committee of Hospital Infection Control of the UST Hospital, a member of the Council of Advisors, Philippine Society of Microbiology and Infectious Diseases. She chairs the Committee on Adult Immunization of the PSMID. She's a member of the Specialty Board of the PSMID. She's a board member of the Philippine Foundation of Vaccination. She's the president of the Philippine Society for Microbiology and Infectious Diseases from the years 1999 to 2000, the Chief Section of Infectious Diseases of the St. Luke's Medical Center from 1986 to 2000. She chairs the Infection Control Committee of the St. Luke's Medical Center from 1986 to 2000. And she attended the 6th International Advanced Course in Vaccinology in Asia-Pacific Regions, International Vaccine Institute at Seoul, Korea in 2006. And she's the chair of the Committee on the Handbook of Adult Immunization among Filipinos. Let's all welcome Professor Remedios Fabra Coronel to talk on the topic of immunization recommendations for the adults and the elderly.
Good morning. Thank you for inviting me to this PNIC convention. I've been to Baguio for about 5 years, and there was a lot of change in this beautiful city. So my talk is on guidelines on immunization of the adults and the elderly. We will be coming out with the new edition of our handbook on adult immunization this coming PSMID convention on November 28 to 30. So if you will be there, we will be giving you this handbook for free. So for this talk of mine, I will not be dealing on the clinical disease and on the epidemiology and on pregnancy and on immunocompromised patients because they are all in the handbook, and some other speakers will be dealing on pregnancy. So in the Newsweek magazine issue of October 1, 2007, it says that vaccines do not cure disease, but they prevent it, which is better. Immunizing 100 people, and you do not keep them only healthy, you stop them from infecting thousands more. So the first vaccine that we have recommended is the tetanus, diphtheria, acellular pertussis vaccine. So it is an inactivated vaccine. Efficacy rate is 100% for tetanus, 97% for diphtheria, and 92% for pertussis. Duration of immunity is 10 years, but maybe up to 30 years if the primary childhood schedule is completed, that is 4 to 5 doses. and the adult schedule is 3 primary series. Please emphasize this, that TDAP is a primary series. It consists of 3 doses at 0, 1, 6, or 12 months. Because what happens in the clinic is, you will give them 1 dose of your tetanus, diphtheria, a cellular pertussis vaccine, and they thought that that's it. So you have to emphasize that they need 3 doses, and to have to give the second dose on the second month after your first month after your first dose, and 6 to 12 months after the second dose. So the use of TDAP, regardless of the interval since the last dose of tetanus or TD toxoid, should be given for the benefit of protection against pertussis. And adults 65 years of age who have or anticipate having close contact with an infant aged less than 2 months should receive a single dose of TDAP, and other adults aged 65 or older may be given a single dose of TDAP. So the recommendation is for all adults, particularly women who are pregnant and healthcare providers with a level of evidence of 1A. So these are the contraindications. If there is the development of Guillain-Barré syndrome within 6 weeks of a previous dose of tetanus toxoid, for adults with unstable neurologic conditions, and for adolescents who have progressive neurologic disease, and moderate or severe acute illness, which holds true for all other vaccines. Now, the second vaccine that we recommend is hepatitis B, which is the first anti-cancer vaccine. And the studies done in Taiwan show that universal hepatitis B vaccination has decreased the incidence of hepatocellular carcinoma in children. And in China and in Hawaii, universal hepatitis B immunization has dramatically decreased the prevalence of chronic carriage. So again, the recommendation is for all adults, healthcare workers, those working in correctional facilities with the level of evidence of 1A, and other indications, household contacts of HBV carriers, recipient of blood products, immigrants from areas of high HBsA endemicity, hemodialysis patients, and IV drug users. Now, the duration of protection is unknown. So should we give hepatitis B booster doses? Up to 10 years in healthy young adults, or up to 15 years in children. However, you can have a lifelong immunity in immunocompetent persons, even though your anti-HBs level falls below 10 ml. And the reason given is possibly due to long-term memory of the B cells. You can also give twin-rix combination of hepatitis A and B vaccines, and it's cheaper with the fewer shots of just 2 for those who have not received any of these vaccines, and your schedule is 0, 1, or 6 months. You can have your accelerated dose, special dose travelers, on day 0, day 7, day 21, and at 12 months. Now, the next vaccine recommended is hepatitis A. Indications: men having sex with men, IV drug users, travelers, or workers in high endemic areas with hepatitis A, persons seeking protection, people with chronic liver disease, especially because of the risk of fulminant hepatitis A, and others. So 2 doses, as I've said earlier, if you give it with hepatitis B of 2 doses at 6 or 0 and 6 to 12 months. Now, for healthy travelers, 40 years or younger, vaccine is preferred over immunoglobulin as soon as travel is considered, and use your monovalent vaccine only, just hepatitis A. Another thing is that there's now a hard time looking for immune globulin. Other vaccine is your MMR. It is live attenuated vaccine. An efficacy rate is 95% with a duration of immunity that is lifetime. So 2 doses, at least 1 month apart. Again, recommended for all adults, particularly adolescent and adults without documented evidence of immunity, especially the non-pregnant women of childbearing age with a level of evidence of 1A. Precautions, it is a live vaccine, so don't give it to pregnant women. And also to those immunocompromised individuals, especially and in HIV, especially if their CD4 count is 200 and below. Now, regarding autism and MMR, which was tackled by Dr. Bravo yesterday, that's the myth. There's a myth that causes autism in children, and this is because of the result of an increase in the cases of autism in 1980s. But in multiple studies, it showed that there's no correlation between autism and MMR vaccines. So don't try to make this as a problem when you are dealing with your MMR vaccines with children and adults. Itapon na nga daw sa basura yung autism na yan. Another live vaccine is your varicella vaccine. So you should give it 2 doses at least 4 weeks apart. An efficacy rate is 99%. In studies done in the US, it showed that antibodies can be detected as long as 9 years, and in Japanese studies, antibodies can be detected as long as 20 years. And some studies show rising antibody levels over time. It's because of the long-lived T-cell proliferative response. So again, it's recommended for all adults, especially those persons without history of varicella infection, all healthcare workers, teachers of young children, non-pregnant women of childbearing age, travelers, military. A very important vaccine is your influenza vaccine. Efficacy rate is 70 to 90% in healthy adults. Why do you give it to adults, especially 50 years and above? Because of its efficacy rate of preventing hospitalization in 50 to 60% of patients, preventing death in 80%. And the efficacy may last from 6 months to 1 year, and it begins to be effective after 2 weeks of vaccination. What is a very important thing in influenza, that's the reason why it should be given to children, to all company employees, because studies in Malaysia showed that vaccination of healthy working adults was shown to reduce work absenteeism by up to 78%. Usually, the index case are the children, so you have to vaccinate the children, because once a child is in the classroom, he will infect other children, and when the children go home, they will infect their parents, And when the parents get influenza, they go to the companies or in the factories, and they will infect other people. And this is the recommended influenza vaccine for 2013, the Southern Hemisphere strains of Influenza A, California, Influenza A, Victoria, and Influenza B, Wisconsin. So again, indications, individuals 50 years of age or older, anyone who wants to reduce the chance of falling ill with influenza, and international travelers, students, or other persons in institutional settings, healthcare workers, pregnant women in the second or third trimester of pregnancy, household members of high-risk persons, and providers of essential community services. We have more indications in our handbook, and other individuals who have chronic illnesses. So contraindications. So before you give this vaccine, you have to ask for anaphylaxis to eggs or chicken, which is a very important component of the influenza vaccine. There is a new influenza vaccine developed, which is the split virion inactivated vaccine. We call it Intansa, of 15 micrograms, and it is given as an intradermal touch. It is an innovation to target the potential of the skin because the dermal layer of the skin is a powerful immunocompetent organ for a direct access to the immune system because of a high concentration of dendritic cells, which control the magnitude, quality, and memory of the immune system, and because of its major vascular networks, density of both lymphatic vessels and blood capillaries favors rapid cellular and antigen for direct access to the lymph nodes. So we have it available. So again, indications. Now this should be 50 years of age, not 60. In phase, 60, that's correct, for Intansa. For the influenza vaccine, the ordinary influenza vaccine is 50 years of age and older. For Intansa, 60 years of age. In phase 3 trial, Intansa elicits a significant superior immune response over the regular influenza vaccine for all strains. Now, pneumococcal vaccine. So we have two types of vaccine available in our midst. The pneumococcal polysaccharide vaccine, PPV23, and efficacy is 56 to 81% in preventing serious pneumococcal disease in low-risk immunocompetent persons, as shown by the Cochrane Studies review of 2008. And efficacy based on randomized controlled trials is 80% and 52% based on observational studies. Another, the newer vaccine, is your pneumococcal conjugate vaccine, PCV13, and can prevent pneumonia and invasive pneumococcal diseases in adults 50 years of age. And it's currently licensed for 50 years of age and above. How is it effective in adults? PCV13 induces an immune response in naive 64 years old that is non-inferior to PPV23 serotypes. And there was a study which showed that it is statistically significant, greater for the 9 of the 13 serotypes, as shown by the geometric mean ratio assessing the opsophagolytic activity. And the response to PCV13 is generally higher in 50 to 59 years of age compared to the 60 to 64 years old individuals. So indications, people 50 years of age, people less than 50 with chronic illnesses, cardiovascular disease, asthma, diabetes, those who are alcoholics, cirrhosis, smoking, with CSF leaks, and with functional or anatomic asplenia. It's IV and immunocompromised patients like those with leukemia, transplant patients. How is it given? A single dose of 0.5 ml given IM or sub-Q. If PCV13 is given first, give PP polysaccharide vaccine 23 at least after a year. And if you have given your polysaccharide vaccine 23 first, give your PCV at least after 2 months or 8 weeks. Revaccination of immunocompetent person is not recommended. However, vaccination may be given to individuals 50 years old and above who have received their first dose more than 5 years of age and before they reach age 50. Now, as long as the patient remains immunocompromised, you can give your PP pneumococcal polysaccharide vaccine after 3 or 5 years as long as your patient remains immunocompromised, not with your PCV. Now, meningococcal vaccine. We have your polysaccharide vaccine, MPSV, meningococcal polysaccharide A and C, meningopolysaccharide ACY and W135, your meningococcal conjugate vaccine, which contains ACY and W135 for children 2 years and above and adults, and is given as a single dose of 0.5 ml IM. Protective antibody is achieved within 7 to 10 days of vaccination. In healthy adults, antibody levels decreased but are detectable as long as 10 years after vaccination. Little boost occurs following repeated vaccination. And revaccination 5 years after receipt of the first dose if indication for vaccination is still exists. So those people who are going to the Mecca pilgrimage can have a revaccination of your meningococcal vaccine, your meningococcal conjugate vaccine. So it is not routinely used, and there are only special situations wherein your meningococcal vaccine can be given. And these are the special situations: college freshmen living in dormitories, those microbiologists exposed to meningitis, military recruits, travelers to hyperendemic areas like the Mecca travelers going to Hajj, to the meningitic belt, sub-Saharan Africa, and people who wish to decrease the risk of meningococcal infection. Another indications, those with asplenia, terminal complement or properdin deficiencies, and with HIV infection. So again, single dose. Your meningococcal conjugate vaccine is preferred for adults who are age 55 years or younger, and your polysaccharide meningococcal vaccine is preferred for adults age 56 or older. So again, revaccination with your conjugate vaccine every 5 years for those who remain at risk for infection. Booster dose is not recommended for healthy persons. 22 years of age or older, even if the first dose was administered at 11 to 15 years of age, your booster dose is not recommended. Now, rabies vaccine. Kahapon pa, ang dami-dami ng lecture on rabies vaccine. Indications, pre-exposure. So, linawin lang natin, pre-exposure means there's no bite, no exposure. You just want to prevent rabies in the future. And who are these who can be given pre-exposure vaccination? Healthcare workers that handle dog bites and rabies cases, rabies research and diagnostic laboratory workers, rabies biologic production workers, vet meds and vet students, animal control and wildlife handlers, field workers like the collectors, mailman, deliveryman, and others, international travelers, as spelunkers, those who are working in the caves. So pre-exposure prophylaxis, uulitin ulit. Ilang beses nang naulit ito. 3 doses of 1 ml of HDCV or PCEV IM, 1 injection per day on day 0, day 7, and day 21 or 28. Or 3 doses of 0.5 ml of PVRV administered IM, 1 injection per day on day 0, day 7, 21, or 28. Or if you want your intradermal, 3 doses of 0.1 ml of PVRV, HDCV, or PCEV, intradermal 1 injection per day on day 0, 7, and day 21 or 28. Booster of single dose, IM or ID, every 2 years. Now, for those persons who are previously vaccinated and now have a history of exposure or dog bites or animal bites, what can you do? You give any of the following 3 doses, 1 ml each of HDCV or PCEV on days 0 and 3, regardless of the interval from the last dose, or 2 intradermal of 0.1 ml of HDCV, PCEV, PRV are on days 0 and 7, and no rabies immune globulin required. So that's the beauty of having a pre-exposure prophylaxis, because you don't need RIG or rabies immune globulin, which is very expensive. Now, typhoid fever. Alam niyo, sa totoo lang, I don't recommend typhoid fever in my adult patients. Because I know they are selective, they know what to eat, the right food to eat, the right drinks to drink. And there was a study done by Dr. Romulo way before, maybe mga 15 years now. It's not cost-effective to vaccinate one person, to vaccinate people just to prevent 1 case of typhoid fever. But we have it recommended for special situations. So these are the indications: food handlers, dietary personnel, cooks, waiters, server, dietitian, nutritionists, microbiology technicians, persons with intimate exposure to S-typhi carrier or patient, and any person who wants to get protected. Especially if you get typhoid fever and your stool exam stool culture is positive for Salmonella typhi, 1 year beyond infection, you are labeled as a typhoid carrier state, and you are very dangerous to other people, especially if you are a cook in a restaurant. So it's better that if the first indication of food handlers, that you be given your typhoid fever vaccine, which is your IM polysaccharide vaccine. Just 1 dose vaccine, booster, everything. Okay, tapos na ako. Ha? Anyway, you were also bombarded yesterday with HPV vaccines. We have 2, Gardasil, protecting against HPV types 16 and 18, which causes cervical cancer in 70%, and 611, causing genital warts of 90%. But even though you give the vaccine, you still need to emphasize in your patient safe sex, and pap smear are still necessary. So it's given routinely to females 10 to 45 years of age and males 9 to 26 years old and men. In the US, 11 to 12 years routine vaccination for boys to prevent penile intraepithelial neoplasia, anal cancer, anal dysplasia, precancerous lesions, and genital warts, especially in the studies in the Philippines, which was done but not yet published. It has a 5% prevalence in the Philippines of genital warts. And you can use it as a catch-up vaccination for males 9 to 26 years of age and females 10 to 45 years old. And we have the other one, the bivalent Cervarix, which protects HPV type 6 and 18, which causes cervical cancer. And given for girls aged 10 to 18 years and routinely given to females 9 to 55 years of age. Both vaccines do not require screening before administration. However, this is very important. Routine cervical screening should be continued. Even after vaccination, as there are other types of HPV that can cause cervical cancer. So special populations, women with equivocal abnormal pap smear, positive HPV DNA test, and persons with history or clinical evidence of genital warts and immunocompromised persons. New vaccines not locally available, not yet, the live attenuated intranasal vaccines, which is applied to the nasal mucosa, which needs no needles, and approved in the US for healthy persons aged 5 to 49, and contraindicated in immunocompromised persons. But then the problem is there is some instability, which could be genetic in nature, and that's maybe the reason why it's not yet available in many parts of the world. And then we have the varicella zoster vaccine, and your varicella zoster virus causes chickenpox. And the risk of your varicella zoster reactivation is the shingle or herpes zoster, which occurs in 2 in 10 people in their lifetime. But in those more than 80 years of age, can be 1 in 2. And 1 in 5 victims develop long-term nerve pain or post-herpetic neuralgia, and you can have scarring and loss of vision. So this is the vaccine, which is Zostavax, a live virus vaccine using Okamerk virus, which is 14 times more potent than the chickenpox vaccine, and induces high level of antibodies, which protect against herpes zoster. Now, indications, recommendations for those 60 years of age and above, whether they had a previous episode of shingles or not. However, it's contraindicated in immunocompromised persons and those with active and treated TB and allergic to this vaccine like gelatin, neomycin, or other vaccine component. The placebo-controlled study of 38,500 people have given vaccine followed for 3 years, and this is the result. For those age 60 and above, it reduces shingles or herpes zoster by 50%. In those aged 60 to 69, it reduces shingles by 64%. and reduces also the risk of post-herpetic neuralgia by 2/3. And in those who received the vaccine but still developed shingles, the duration of pain was reduced. A separate study, incidence of serious adverse events was 1.9% for those who received the vaccine and 1.3% for those who received placebo. Duration of protection is unknown, so we don't know yet whether booster doses has to be given or not. So these are the vaccines strongly recommended: Tdap, hepatitis B, influenza, varicella, MMR, recommended pneumococcal vaccine, rabies vaccine, for selected individuals, rabies vaccine, meningococcal vaccine, typhoid vaccine, and hepatitis A. My last parting word is this: anyone who wish to receive the vaccine, whether you like it or not, should be given the vaccine for protection. Wala kayong problema, gusto ko di bigyan mo. And that's my last words. Thank you.
S. Pre-Med, College of Science at the University of Santo Tomas, Manila, magna cum laude. Had her Doctor of Medicine at the University of Santo Tomas, Manila, cum laude. Had her medical residency at the UP Philippine General Hospital. Was a research fellow for infectious disease at the UP Philippine General Hospital. Finished her Master of Science in Clinical Tropical Medicine at the London School of Hygiene and Tropical Medicine, University of London. She is a Professor 1 at the UP College of Medicine. She heads the infectious disease section of the UP Philippine General Hospital, an active consultant at UP PGH, where she chairs several hospital committees such as the Anti-Rabies Unit and the Animal Bite Center. She is a member of the Adult Immunization Task Force of the Philippine Society for Microbiology and Infectious Diseases. She's a member of the Immunization Safety Board of the DOH. Our speaker has conducted numerous research works and clinical trials on vaccines and other infectious diseases, and has published her research outputs in local and international journals. She has authored several handbooks on animal bites and immunization guidelines and contributed to chapters of books on infectious diseases. Let's all welcome Dr. Maria Cecilia S. Montalban to talk on immunization recommendations for healthcare workers.
Thank you, Victoria. Okay. So, our topic, at least for this next few minutes, is healthcare workers vaccination. So, but before I start giving you the list of vaccines that we need to give our healthcare workers, I'd like to start with a little story and ask you, is this fact or fiction? I'm sure you've seen this on TV, di ba? So, we start with a story of a 22-year-old female nurse who one day prior to admission had a pimple-like lesion on the face. 6 hours later, more lesions developed on the trunk, and a day of admission, she had generalized lesions, maculopapular, vesicular lesions all over. What do you think this patient has? Chickenpox? So varicella or chickenpox. So this patient was admitted. She was given acyclovir, which is a drug of choice, antiviral for chickenpox. Was given also paracetamol, antihistamines, and she went into sick leave for 10 days. 1 week later, other nurses and paramedical personnel also were affected. Interns, nurses, medical students, etc. 10 days later, 2 newborn babies were also affected. So I think this was, okay? So what do you think? Is this a fact or a fiction? It is fact. In fact, this is with just revision of the characters in this story. This is exactly what Dr. Montellano showed us yesterday about the chickenpox outbreak in the nursery at a tertiary hospital in Manila. Okay? So the facts are, one patient was given at least 35 tablets of acyclovir 800 milligrams, which cost approximately about 300 pesos per tablet, or a total of 10,500 pesos for the whole course. Antihistamines and some prescribed multivitamins, about 500 pesos. Antibiotics were given because patient later on developed bacterial infection. I placed there as about 1,500. And loss of income for 10 days, I just averaged it at 500 pesos per day as a basic salary of the nurse. So a total of 17,500. I'm showing this slide just to show you that if these patients or these nurses, these medical personnel, these healthcare workers received varicella vaccination months or earlier, she would not have spent 17,500 pesos. Okay? So this just goes to show you that it is cheaper to prevent an illness, an infectious disease, by vaccination as compared to treating the disease. So that's why it's important that we vaccinate our healthcare workers, because healthcare workers are the ones who spread the infection to patients and other healthcare workers. Okay, so healthcare workers covers both private and public workers, which include but not limited to first-line workers such as barangay healthcare workers, doctors, nurses, and other related medical personnel. This also includes support services like ambulance drivers, dietary, housekeeping, etc., even security guards in the hospital. Also, in teaching hospitals, this also covers students on clinical rotation, including nurses, medical students, nursing students, medtech students, physiotherapy students, etc. So you see here a list of healthcare workers. This is arranged alphabetically, not according to importance. All these healthcare workers, first-line workers, are important, but alphabetically they are the barangay health workers, clinical pharmacists, the doctors, nurses, nursing aides, phlebotomists, pulmonary therapists, physical therapists, radiotech, students on clinical rotation. Then we also consider the support services in the hospital. These are the admitting section personnel, the ambulance driver, the clinic secretaries, dietary, nutritionist, engineering, the the IT personnel, janitorial services, lab personnel, linen, laundry, morgue personnel, office workers, pharmacists, public health specialists, security personnel, social workers, and other medical personnel in that hospital or institution. So you see, healthcare workers are not just nurses and doctors. These are all healthcare workers, and these workers need to be vaccinated. However, the problem is healthcare workers often think they're immune, and that's a really big